wa rahmatullahi wa barakatuh. Ladies and gentlemen, thank you for accepting me to be here, and thanks to Novartis for asking me to give this talk. The lipid talks can be boring, but the reason we keep hammering about it because we're not doing it very well, really. The title of my talk is Inclisiran, Confidence in Long-Lasting LDL Control. What I'll try to take you through is the ongoing risk of cardiovascular event in patients with hyperlipidemia, the impact of lowering LDL on this cardiovascular risk. One slide summary of the 2019 guidelines, just to remind us about really, and we have to keep it in our mind and maybe have it in our phone, whatever. And the commonly used LDL lowering therapy, going through the base PCSK9 targeted therapy. A couple of clinical cases from our institute, and the efficacy and safety of Inclisiran, the Orion 9, 10, and 11, and the evidence for long-term safety and efficacy of Inclisiran, the Orion 8 trial. And then, are we doing enough? Should we do more for the LDL? And the concept of the combination of lipid-lowering therapy as first line. And then just some slide of the Inclisiran. So having hyperlipidemia is really bad for you. We know that anybody with people with hyperlipidemia, as we've seen from this registry or observational study of 123,000 patients with hyperlipidemia, primary and secondary, following up for 2 years, up to 40% will have at least one cardiovascular event. So this is people on lipid-lowering therapy. And we know from this large REACH registry, which is an international study of really 29 countries all over the world, of people with what we call established, stable atherosclerotic cardiovascular disease, 45,000 on lipid-lowering therapy. And guess what? These are stable, fine patients. At least a third of them will have an cardiovascular event in the following 4 years. People who come with acute cardiovascular event, acute myocardial infarction, as we've seen from the Swedish registry of nearly 100,000 patients following MI, in the first year, 1 in 5 will have another cardiovascular event. This is really, European centers and, on the best treatment. And 1 in 5 will have a cardiovascular event. So, does lowering LDL really have an impact? Of course it does. We know this for a long, long time. Whether it's primary or secondary prevention, if you give them lipid-lowering therapy, the lower the target, as we see moving to the left, is the lower the risk. So the more recent trial actually started with even lower LDL and went for a lower target, and yet continue to achieve a benefit. And our cardiology godfather, Eugene Brunwald, he just wrote this paper, call it cholesterol race to the bottom, and in which he just highlighted that, as I mentioned just earlier, that the more recent trial, they starting with even higher LDL and moving to a lower LDL, up to 2.8, and they're still getting benefit. There is no lower limit to your LDL. We have to get this in our mind and, get this fear of having low LDL is bad for you. And you have, this rule of thumb, 1 millimole reduction in LDL will give you 28% reduction in your cardiovascular event. So you can make the calculation. 3 things you need to remember when you are, starting somebody LDL and what you want to achieve. There are 3 things you target. First, you want to reduce your LDL by as much as you can. So the higher LDL reduction, the more you get the benefit. Of course, the second thing, the higher risk is your patient in front of you, the more benefit you will get, yeah? So if you start with a very high risk, whatever reduction you will get benefit. And the more LDL you reduce, the higher the figure that you reduce by, the more the benefit. But to me, more important than these 2 is keeping the LDL down all the time. There's no point of bringing it down to 0 for a month and then you just forget about it or give them a statin and then just don't follow the patient, whatever. And we know this really. If you follow a patient from the randomized trials that goes up to 5 years, the higher LDL on the right side, the higher LDL reduction to the 2 means you reduce by 2, then the more the benefit, the higher the rate of benefit. And we know also if you keep that LDL for 12 years, as we know from observational studies, by the same magnitude, by the same 2 millimole reduction, you get even higher benefit. And if you are lucky, if you have the right genes, if you have the genes that have low LDL all your life, like we know from Mendelian, like if for 52 years, you get the best benefits. So keeping LDL low for long, not just keep it low only, as low as you can for as long as you can all the time. So you have to check your patient, you have to monitor the LDL, you have to do the test, you have to follow them up. There's no point of giving them one tablet and just forget about it and say they are on statin, they're fine. And all our patients we see are very high risk, all of them, okay? All established ethics authorities, whether it's clinical or subclinical. So the LDL has to be less than 1.4 and not or more than 50% reduction from the baseline. And if they have 2 events within 2 years, your target should be less than 1. So you really have to hammer it hard. There's no lower limit. Okay, how we reduce it? You can give them a statin, but give brief high intensity statin. Don't give 10 milligram of atorvastatin, and with that you get 50%. But even with the statin, you still have a very high residual risk. You can add ezetimibe, which can give you another 18% reduction, which is good, beneficial, and it has evidence behind it. But what we know that 50% of patients will stop their statin within 2 years. We know this. This is true. This fact. They stop it. Unless you see them every week and keep hammering them about it, with side effects or without side effects. What else can we do? We have the PCSK9 target therapy. Just really briefly to go through how this thing works. The liver is the maker and breaker of cholesterol, yeah? So you have this your LDL receptor on the surface of your hepatocyte that sucks your LDL, get it inside the hepatocyte and destroy it. But the LDL survives, go back to the surface of the hepatocyte and keep doing this for 200 times. So one LDL receptor works 200 times before it dies. Okay? God we have auto-regulation system for everything. You bleed, you clot. That's true. Same for cholesterol. Your system has this stuff called PCSK9, which is for us is the bad guy, because what it does, it is produced by the liver, goes into the hepatocyte surface, combined with the LDL receptors, go inside the cell, and the LDL will be destroyed, but also the LDL receptor will be destroyed. So LDL receptor will be used only once. You will have less LDL receptors on the surface. You will have a higher LDL. And we know this. Sorry, I didn't mention. So the PCSK9 inhibitors, they are monoclonal antibodies that goes inside your blood, clean out the PCSK9, so it frees the LDL receptors. And we know they work from the 4-year studies. People established coronary artery, established cardiovascular disease. They're very effective, and they have a cardiovascular outcome. And they see in the people with acute coronary syndrome, they have eulogumab. These are the monoclonal antibodies, PCSK9 inhibitors. They are good and well, but provided you take them regularly. If you skip, then your LDL will fluctuate and you've done nothing. And we know from database from the insurance in the States that 50% of people on PCSK9 inhibitors, they interrupt their treatment for at least a month. And we know like by 1 year, 27%, they will not be even taking it. So can we have another treatment that we can give it less often so we can get more compliance and it's effective? Yes, we have the Inclisiran, which is small interferon RNA. As the name implies, it does interfere with the messenger RNA. So it is injectable, it goes into your system, it goes only to the liver, no other organ, and it's sucked into the liver and disappears from your system within 24, 48 hours. What it does goes into the hepatocyte, goes into a combined called RISC, RNA-induced silencing complex, and what that complex does goes inside the cytoplasm and find the messenger RNA for the PCSK9 and destroy it. So destroy the messenger RNA. If you destroy the messenger RNA, you will not produce PCSK9. So you close the tab. You stop the production of PCSK9. Not just cleaning it from your blood, but you stop production altogether. And it's cleaned within 40 hours. Does it work? I will just take you quickly through a couple of cases. In our center, the 73-year-old man, typical case you see every day, ischemic cardiomyopathy, multiple BCI, cabbages, etc., diabetes, hypertension, dyslipidemia. He's on very good statin therapy plus ezetimibe, yet his LDL is 4.1. In February of last year, we started him on Inclisiran, and look, His LDL dropped immediately to less than 1. It remains less than 1 till now, and he's free of cardiovascular event. Another lady, 46, non-ischemic cardiomyopathy, but she had a ischemic stroke, hyperlipidemia, diabetes, etc., etc. She's not tolerant to statin. She takes very small dose, if at all, with the istimab. Her LDL is what? 6.2. We give her inclisiran, drop to less than 1, and it remains less than 1. And we can still see her, and she's doing fine. Do you have evidence from really large clinical trials? Yes, of course. There is a large Orion program that you probably all hear about. I will just mention the phase 3 because they're clinically important. Orion 4, we are all awaiting for because it's a cardiovascular outcome trial. Will come probably 2026, I think. Orion 5, I'm not going to talk about because the homozygous familial hyperlipidemia. Orion 8 is an extension, which I'll mention, of open label extension of 9, 10, and 11. So 9, 10, and 11 are very similar design trial, 18-month trial. Patient get only 4 injections. Only 4 injections in 2 years. 4 injections of inclisiran. 9 is heterozygous familial hyperlipidemia. 10 is people who establish atherosclerotic cardiovascular disease. 11 is like 10 plus risk equivalent. So very similar, more than 3,500 patients. And they had 4 injections of inclisiran. And what happened? Their LDL dropped by 50% from baseline. And more importantly, we have consistent 54 reduction in LDL throughout. So the LDL remain low, does not fluctuate throughout the study, but just by 4 injections. You can say, okay, and it is very safe. It doesn't matter what statin you're on, whether you're on statin or not statin, high statin, low statin, it works. Obviously, they have ad effect. It reduces all your lipids components and reduces your bad PCSK9. Your bad PCSK9 is your enemy. It reduces it significantly. It reduces all the lipids components, including the lipoprotein little a. And it's very safe, only local reaction, transient, nothing else. It has no effect on your liver, kidneys, platelet. It's fine. Do we have a longer than 18 months? Yes, we do. Because you say this 18 months, it's a very short study. This is what the Orion 8 did. The Orion 8 took the people from Orion 9, 10, 11, and they took them, enrolled them into open label inclisiran. They gave them all inclisiran. More 3,274 patients, and followed them for another 3 years. And guess what? Same thing, really. 80% reached their target LDL. There was 50% sustained, remember the word sustained all the time, LDL reduction, and it was safe. So with the Orion 8, we have now data for more than 6 years of a significant, stable, sustained LDL reduction without side effects, with mean exposure of 2.6 years and total inclisiran exposure of more than 8,000 patient years. Now that comes to us now. We have all this armamentarium. Are we doing what we are not? What we are supposed to do? We are not. We are not. This is the Davicini study. This was published 2020, long after the 2016 guidelines, just after the 2019. So, and looked into a record of 6,000 patients with hyperlipidemia in 18 European countries. And guess what? They found basically that 45% on what? Just moderate intensity statin only. 37% others are on high intensity statin. Only 9.3% on istimab. Only 1% on PCSK9 inhibitors. This is in Europe. And obviously the effect that only 39% reached the target LDL of 1.8, not 1.4. You can say, okay, this is this is all data. Now we have the 2019. We are better at it. We can do better. We are doing better. No, you're not. Centurion trial just published last year. Again, similar to Davicini, 14 European countries, 9,000 patients, looking at the use of LDL after the 2019 guidelines. And guess what? We're doing worse. 21.8% not on any lipid-lowering therapy. 54% are only on one monotherapy. 80% did not reach the target. Terrible. That's Europe. And the paper concluded clearly, it's doctor's fault. We are not good at cardiovascular risk estimation, and we're not good at using combination therapy. We give them atorvastatin at best 40, and we never even check their lipid, and yeah, they're on statin, they're fine. They look for some other reason for their ill health. In the States, similar thing. This is the gold registry of 5,000 patients with established cardiovascular disease. And guess what? In 2 years, only 17% have their lipid-lowering therapy intensified. So nobody just put them on treatment and didn't do anything. No, this is in the States. And only 12% with that reached the target. Closer to home, the DICES-2 trial, again, this international study, but involved the European, Middle East, and Gulf countries, 10,000 patients of established coronary artery disease or acute coronary syndrome. Guess what? Really similar. More than 70% did not reach a target of 1.8. And 84% are on monotherapy. God knows, one statin and that's it. And even closer, this is the Gulf Action study of 5 Gulf countries, 3,000 patients with established cardiovascular disease. Very similar, sad story, unfortunately. Only a quarter reached the target. It's doctor inertia. We're lazy. And this fact, this is a paper from Spain. They actually sent survey to 155 cardiologists. Survey, you can lie, you can do it, you can say whatever you want. Ask them about their attitude of initiation and up titration of lipid therapy. And what they find, that up to 50%, they don't do that. They have the attitude of, we don't really bother, we don't initiate, we don't up titrate. This is. What about the media? Media, good and bad. But it can tell you statin is good for you, but it can tell you all the rubbish. That statins can kill you, lower lipid LDL will make you crazy, the 10 terrible effects you get from lipid-lowering therapy. And you think this doesn't affect really us, it doesn't affect the patient. It does really, and this has been documented here. This is a paper we looked at when there's a big hype of risk, statin is bad for you, lower lipid bad for you, and was associated with actually increased discontinuation of statins. And not only this, and that was associated at the same time with increased incidence of myocardial infarction and cardiovascular death. So media does play role, bad or good. And this actually led to the American Heart Association to come with a statement regarding, how safe that LDL is not bad for you, and you have to get to the target. And what in their statement, saying that we are actually fortunate that we have now non-statin therapy that can lower your LDL with evidence of benefit, and there's no lower limit, and it does not make you go crazy. It doesn't affect your brain, and the new paradigm should be lowest is best. Okay, so how can we improve lipid management? Now, these are the top lipid specialists in the world, came up with this paper in the European Heart Journal, and they are proposing or recommending or advocating that combination, not one agent, combination lipid-lowering therapy should be the first line, not second, third line, first line in the very high-risk patient. All your patients are very high risk. Do not underestimate, okay? Remember this. And they came with this paradigm, tell you that if your patient is very high risk, you start him with a combination statin istimab. Within 4 to 6 weeks, if the LDL doesn't reach target, you add the PCSK9 target therapy. And they are extremely high risk, had 2 events within 2 years or multivessel, you start with cerebral therapy straight away. Okay? Okay, it doesn't matter how you lower it, just lower your LDL. If you have the good genes, that's fine. If you can do it with statin, fine, but 50% will stop their statin. If you can do it with PCSK9, fine, provided you can do it 26 injections. But if you can do it twice, injection per year is better. If you can get the vaccine 2 injections in your life, if you can modify your gene, it will be the best. So basically, Inclisiran gives you sustained effective LDL reduction. It is one injection. It does not require monitoring. Doesn't require refrigerator. Doesn't affect your kidneys. You can give it even dialysis patients, and it's clear from your system, and it is safe. It's FDA approved by the NICE and the FDA for atherosclerosis and lipid-lowering therapy. And thank you. And I did it in 20 minutes.